Hello, everyone, and thanks for joining what lies ahead for the EHR's Problem List webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode. So if you have any questions, please type them into the questions section in your GoToWebinar panel. At the end of the presentation, we'll have a Q&A sessions as well, and we'll get to as many questions as we can, but if for any reason yours is not addressed, someone will follow up with you after the presentation. Today we have three physician informaticists from IMO presenting. And before we get started, as mentioned before, if you have any questions or comments while our presenter is speaking, just type them into the questions section. After further ado, I'm going to pass it over to Dr. Jim Thompson, who will serve as our moderator today.
Hi folks, Jim Thompson here. I am a physician informaticist with IMO. By way of background, my boards are in internal medicine and emergency medicine, spent a few years in clinical academic internal medicine, most of my career, about 25 years in the emergency department. I've had a little experience as a CMIO, about 10 years building out an electronic health record in the western suburbs of Chicago. And then segued out into the vendor world, both on the development and strategy side. And now I'm an informaticist with IMO. I'll let my partner, Dr. Gold, introduce himself next.
Hi there, I'm Jonathan Gold. I'm also a physician informaticist at IMO, working with some of the clinical innovation team. I'm a pediatrician by training, practiced for about 15 years. Also worked with as a CMIO for a number of years and in medical quality assurance. And I will go ahead and pass the baton to my comrade, Dr. Deepak Pillai.
Hi folks, thank you for joining. My name is Deepak Pillai. I'm a physician informaticist as well. By way of clinical training, I'm an adult neurologist by background, but most of my career has been in industry, focusing on providing, developing and implementing solutions around my areas of interest around patient safety, physician workflow, and problem list management. I'm excited to be here to share some thoughts on those topics.
Thanks a lot. So, I think we ought to set the stage by sort of agreeing or at least speaking to the topic of the role of the problem list in an electronic health record. Before I do that, though, I want to make sure I give a shout out to everybody on the call. Here at IMO, we create terminology for most of the electronic healthcare world, both in the United States and for that matter around the world. And our success is due in large part to those of you on the call, folks like consultants, developers, clinicians, vendors of an electronic health record. So thank you for the work that you've done. As I mentioned, to set the stage, I think we ought to kind of consider what is the role of the problem list in an electronic health record, or maybe more precisely, what should that role be? If you look across our industry, you will get an opinion around what the problem list is supposed to be, what's on it even, and how it's supposed to work for a clinician. You'll get a different answer from every single person you talk to. What you see on the screen here is sort of a summary of, a summary of one way to think about the problem list from our Chief Medical Officer here at IMO. And that is that the problem list at some level is supposed to present clinicians with a quick snapshot of the patient's active diagnoses and key health issues. I can tell you from my role in talking to clinicians, the key word there is quick. I have to be able to go to an electronic health record and somewhere in that electronic health record get an overall picture of what's going on with the patient. And I think historically, that's where we've positioned the problem list inside both the paper record and the electronic record. How do I go to this record and say, this is what's going on with my patient? Jonathan and Deepak, you have both done a lot of work here at IMO around the problem list. Any further comments about where the EHR positions the problem list and what it's supposed to do?
Thanks, Jim. I'll go ahead and take a stab at that. I think that I actually go back historically, prior to the EHR, just to the medical record, and think I always bring up Larry Weed, and if you're familiar with him, if you're not familiar with him, he was a physician who really led into a more formal way of framing the medical record, and he pushed very much for a problem list, that guide, that index to patients. This was in the early 60s and beyond, and he would take out a physician's notes, the notes on a patient that could be this big, and say, okay, what are the problems this patient has? And he would show the audience members, who were all docs, that it's quite impossible to figure out what's going on with a patient unless you do have some sort of quick guide to help them, and that index being the problem list. Deepak?
Yeah, I couldn't agree with both of you more, and many of you on the phone are here to understand how problem lists can help clinical care. But I also want to emphasize that the content that's in a problem list can really help drive a variety of downstream functionality and making the overall EHR experience an enhanced one, be it for clinical care, decision support, patient education, regulatory reporting, and so forth. So good content and a good problem list can just make the overall experience better in addition to patient care.
Thanks, Deepak. So one place where we could start talking is, what's the state of the art? Where is the problem list right now in the industry? And I think if I went down that road, I would probably get an answer from every single person on the call listening who's worked with this. And so I don't want to spend the entire hour just talking about what's wrong now, but I do want to make an observation as somebody within informatics who's been working with this for a long time. And that is that one of the things that feels to me like went wrong when we went from paper to an electronic health record is we essentially took the paradigm that was available on paper. What I have here is a list. And so we just took that paradigm and said, all right, I'm going to make an electronic list of the same thing. And a problem list like that is not particularly helpful. You're looking at a real world list. This one was given to me by one of my colleagues about 10 years ago, and I stashed it away. There's part of this list that seems like a good idea. In this case, I'm going to have a computer go in, mine the chart for all the diagnoses. You can see these are ICD-9s because this is about 5 or 10 years old, and I'm going to give them to the clinician. And the most a computer can do with that kind of a list is maybe clean it up so that it's a little bit easier to read, but it doesn't expand on that paradigm of a two-dimensional problem list that sits in the paper world. We can do so much more with the computer, and I think to a certain extent we're starting to get there. You know, sort of out of the box, we probably gave the developer the job of creating this list, and they did that, and maybe it was in a tiny little box somewhere. One thing the computer can do, for example, is start cleaning up how that display actually comes forward to the clinician. But I think we can do a lot more than that. And so rather than focus on where the EHR has come so far, we want to spend the rest of the time here talking about what the approaches are for actually improving the problem list itself with the help of the computerized world, the electronic health record world. And so since this is the most central, most difficult piece of what we want to tackle, Deepak, I'll hand it off to you first to talk about some of the places that we can start improving the problem list as it exists inside the electronic health record today.
Yeah, thanks, Jim. And thanks for those introductory remarks. My colleagues here and those of you on the phone also have your ideas where you'd like to see problem lists go. I do think just one notion I'd like to share with you all is that an effective problem list, I think, should have 3 foundational components to it. First of all, the content itself has to be able to be searched, identified, and captured with the right clinical intent. And for a chronic problem list, that clinical intent, or the specificity rather, is very different than an encounter-specific list. So things like initial encounter, all the various ICD details and specificity may be appropriate for an encounter-specific list, but content needs to be curated more for clinical purposes on a chronic list. So good content is a foundational step. Secondly, and we'll talk more about this in a moment, but organizing information is helpful, and keeping content clean. Jim alluded to this concept of going away from just two-dimensional problem list. And the way you do that is by making the problem list an engaging, interactive tool. Step one is organizing the content. There's different ways in which we can organize it, be they clinical categories, specialty views, organizing labs and medications and so forth, a variety of different ways, but organizing it in a meaningful way. And then keep using technology to keep that content clean. So enhanced management of the content. And then thirdly, calling to attention any conditions that should stand out beyond other conditions. So for example, high-risk conditions or conditions that have a lot of complexity to them, not just from a risk-based reimbursement model, but even just from a clinical care perspective. So how can you call to attention any conditions that need to stand out more than other conditions? So those three components: content, problem list management, and calling out specific conditions.
Thanks, Deepak. If I had to kind of summarize the sort of the overall perspective of that, it would be that what I want to do as a developer, and frankly as a clinician using the electronic health record, is I want to get to a place where the problem list actually diminishes my cognitive burden of processing all the data inside of that chart. Because if it can diminish the cognitive burden, then I can actually improve clinical care. If the problem list is simply one more place where I'm supposed to go in the chart and sort of do a review of a thing that sits in the chart, but it's not this three-dimensional idea that goes out and helps me assemble data into information, then the problem list isn't doing me very much good. In fact, it's just kind of increasing my cognitive burden. I've got to go through that whole list line by line and figure out what's going on with the patient. Now, let me give you a kind of a graphic example of that. You know, I've got a patient with a whole list of problems. And the problem that I want to focus on is that that patient has a renal mass that's buried somewhere down in their problem list along with all their other problems. Well, associated with that particular thing that's going on with the patient is a host of data in the chart. There might be data around medications, there might be data around laboratory values, there might be data around imaging studies and so on. And I've got to take that data and I've somehow got to bring it together in the context of that particular problem so that I've got some information that I can ultimately make a judgment around. This guy's got a renal mass, he's got a history of clotting, he's on blood thinners, and by the way, his current blood thinner amount is too much, so I got to be careful biopsying him. And if ultimately the decision I want to make is to biopsy that, it has to be in the context of everything else that's on the chart. A problem list should help me get to the point where I can make that decision, and it should do it in a way that diminishes my cognitive burden and it doesn't increase it. And I think that's one of the things that we kind of want to flesh out a little bit on this discussion, is how can the problem list actually do that. You know, at IMO, our core competence over the years has been to bring you terminology, accurate, complete terminology, lets you say exactly what you want to say, goes beyond ICD-10, beyond SNOMED, and so on. You know that kind of talk from us around that. And what we've been focusing on in our little clinical world here is how do we help you get to problem-oriented charting? It isn't just that this is an initiative broadly in the industry, it's that it really can help decrease the cognitive burden. You're looking at some data on the slide here that's from a study that I think was out of Dr. Joel Buchanan at University of Wisconsin and his team there, trying to actually quantify how much difference it makes if we can have a problem list that actually helps us get to problem-oriented charting. And by that, we mean get to a way of looking at the electronic health record that says, look, if I take this particular problem, or maybe more precisely from my perspective, this particular problem area, and I can chart against it, I can tell a story around that patient that brings everything together so that either for decisions that I'm making or decisions that the next clinician is making, I can decrease the cognitive burden. I can have fewer errors. That to me is the single most important thing. I can be more satisfied with the electronic health record, and I can diminish what it takes for me to process through that. Deepak or Jonathan, do you want to add any comments around this idea of problem-oriented charting?
So I think that one of the important pieces of the problem list is it gives us a general overview of that patient, but having the ability within the problem list to see those additional pieces, and that is that problem-oriented chart, that problem-focused chart, allows us to really hone in on the problem that we're facing at this moment with this patient.
Okay, so if we want to move beyond just a list of diagnoses, for example, Jonathan, I know that you've done some work around looking at what's landed on the problem list already and saying, look, is there a way for the computer to kind of help us make better sense out of this particular problem list, maybe make it more efficient in some way? And some of the specific work that you've done is in the area of sort of merging problems into a more synthetic whole, and maybe also kind of evolving problems as they go along. Let me have you chat that up for a little bit.
So those are, the computer is actually can work for us as a tool, and we don't always take advantage of that. Two of the ideas that you are raising now are merging problems and evolving problems. And I just want to give a quick definition of what that looks like. When you're merging a problem, you're taking certain tokens of data. So as a pediatrician, I can give the example of a mother comes in with her 3-year-old and she says, my 3-year-old has had fever. And that's my initial piece of information. And then I come up with some sort of working diagnosis. And of course, as a pediatrician, my fear is always, oh my, it could be meningitis. The patient or the patient's mother in this case might give me additional pieces of information, like there's a low-grade fever. It's actually 3 days, typically in the morning. And my diagnosis changes. It's a working diagnosis. So I'm merging these additional pieces of information, these problems, into now it's, well, maybe it's influenza. And I'll gather more information. There's fever. Well, if there's fever and vomiting, maybe it's pneumonia. And ultimately, I'll hear that final piece of that final token of data that will set this into a much clearer light and realize this is not really going to be pneumonia. It's going to be something else. And if there's pus from the left ear, well, it kind of becomes clear that probably this is going to be the left peroneal otitis media. It fits all of those. I'm actually, I use this example, and typically the way that we're using problem lists is we take a problem, we see whether there's a related problem or something that might be put together. This was a very rapid one, so I'm not really writing each of these things down on the problem list, but I could do the same thing on a problem list with a much more complicated problem that develops over time. That's a merging. I was just going to say that's an example of a merging problem merging problems.
Let me clarify that a little bit. So if I'm merging all those problems, and let's say I realize you're just giving an example, but the idea is that the problem list has a number of things on it that have kind of been added over time as stuff comes along, and I want to merge it into a single problem. Is one of the critical factors there that when I'm merging it, I retain any information that's been tied via, say, problem-oriented charting to the previous chart, to the previous problems, and bring it forward to the problem that's actually being displayed here, the left pleural otitis media. So when I'm merging a problem, I'm gathering up the information that's been put against other problems in the past and bringing them all into a single sort of synthetic merged problem. Is that the idea?
That is. And again, depending on how you're building this out, it may very well be that you're starting with a type of chronic problem and an additional chronic problem, and ultimately you realize these are all different aspects. I mean, as the graphic has the 6 blind men touching the elephant in different parts of the elephant, we're actually trying to wrap this up, if it makes sense, into a single diagnosis. So that was where we were going with the merging. There's also something which I refer to as evolving a problem, and we feel that you begin with something as, I would say, simple as a mass of the left breast on a mammogram, and that's the piece of data we have. We don't know more at the very beginning, but as you move forward, you start determining more and more information. In this case, we can do a diagnostic test, find out that it's actually a left breast carcinoma. Over time, we find additional information, like we have staging for that left breast carcinoma, and beyond that, we have those other pieces such as radiotherapy, and later the person is state post radiotherapy, that we've done a left breast lumpectomy. Other things are occurring, and the problem seems to evolve over time, and our marking of what's happened evolves over time. We could put this all together, and as we move forward, and say now, as the problem has evolved, it's now a history of malignant neoplasm of left breast. Underneath all of that, though, if we were to collapse it, we would still want to probably keep on our problem list that his malignant neoplasm of the left breast, but know that there's a rich bit of information that we would like to be able to access rapidly if we're focused on that. If this patient comes in, for instance, with sudden back pain or difficulty breathing, it's very important for me to know that there was that history of a malignant neoplasm, and I would probably want to go back and review what had happened with that, as well as do the diagnostics to find out whether we're talking about some sort of a spread of that.
Yeah, I think there are so many moving pieces to this idea of managing the problem list, because if we don't manage it, we're back to that original slide that I showed, where it's just an aggregate of all of the stuff that's ever been put on the patient. That kind of problem list doesn't help anybody. When that list was given to me by one of my colleagues, his comment to me was, my main concern when I saw this list was, how do I get Smith to take care of this patient instead of me? Because you go into what becomes an aggregated list of everything that's ever been said on the patient. And if you haven't been able to merge anything under a more synthetic idea, if you haven't been able to evolve problems and kind of tie the things that happened in the past underneath a better display header, you get these problem lists that are enormously long. And we hear from many of our customers when we're on calls from them that, hey, I don't even use the problem list because it's just too tedious to get through it line by line. So, we've been working here at IMO, and I know some of you have at your organizations as well, on this idea of actually managing the content. Now, one place that people start is governance. I just want to set that aside for the moment, because the idea of governance, I think, is very important. Did a webinar on it not too long ago, and at some level, the notion there is, hey, look, either I or my committee is in charge of what lands on the problem list. This is what needs to go on there. I think that's very important. And I think a certain amount of governance around sort of cleaning up your own lists is also important. But it's very hard to drive across hundreds of clinicians associated with a particular institution. And so one of the things that we started working on is this idea that, well, look, maybe we can bring some tools to bear that will help manage the problem list content and help manage cleaning up these lists that just become horrendous over time. We don't want to be prescriptive here, and I'm not making a pitch for a product that we make in particular, but I do want to use an illustration from one of our products. Put it on the screen and let Deepak talk about it a little bit, because this idea has been near and dear to our hearts, and we think that this general area of managing the problem list and cleaning it up is a pretty important thing to focus on.
Certainly, Jim, I'm happy to tackle this one. And I couldn't agree more. Governance is critically important, but there's no amount of rules, or they're rules and guidelines, and docs it'll be hard to get everybody to, expectations are there to keep problem lists cleaned up. But if you don't have the right tools, providers it's going to be very difficult to get everybody to do everything all the same way all the time. And so this is where tools to make problem lists a dynamic a component of the EHR comes in handy, where it can, when providers do want to use it, or when things kind of start going in disarray, bring them back and with easy to use functionality. And so I alluded to this earlier, in fact, and I think, Jim, you talked about this as well, is this notion of keeping the content clean. It's, I tell my kids all the time, the first step to keeping things clean is to get organized. We talked a little bit about that already at the beginning, but you still got to clean up, right? And so where can we identify, where can we make it easy for providers to identify those cleanup opportunities? And so the software or EHRs, third-party vendors like IMO and so forth, we can use metadata and information to make that task as easy as possible. And one way to do that is to use information to identify these candidates for cleanup and present it to providers in organized manners. So, for example, what you're seeing on the screen is one way to organize cleanup candidates in terms of all those conditions that have lapsed in time, right? So those closed simple fractures, acute inflammations, the pregnancies that have stayed on charts for years, right? How can we easily identify those and present them to the provider using time-based parameters? Using conceptual meaning of terms, how can we identify exact duplicates for providers and say, hey, this problem list has two different ways to say Lou Gehrig's ALS, two different ways to say CHF, and so forth, and proactively tell the provider that. And a third way to do it, and I get excited about this from a clinical perspective, is using the clinical relation of content. And this is where IMO is our core competency, right, which is around clinical terminology. Using the clinical relationship of concepts to identify conditions that are not duplicates of each other, but are perhaps clinically related and perhaps don't all need to go on the problem list at the same time. Disease progression through various stages is a classic example, and this screen shows an example of that with renal disease. So using metadata to help keep a problem list cleaned up and presenting that to the provider can help make those governance policies that much more effective when providers have the right tools.
Yeah, thanks. I want to add one more comment around that, Deepak, and that is that, this kind of tool or this kind of paradigm, this kind of idea, where I'm looking at a problem list and saying, what's the extra stuff on here that doesn't have to be on here? At least it doesn't have to be displayed in the summarized version of the problem list, so to speak, the actively displayed problems. One place we would really like to see this go from an IMO perspective, having talked to a lot of customers, is when you get an inbound list from another organization. If you think about this issue in medicine, we're all going to interoperability. Our problem lists are already too long. They're too long for me to process from a cognitive perspective, so I want to manage that content in the house. I want to be able to clean up what's on there in the house, and maybe I get that done at my organization, but now we say, okay, we're in a better world of interoperability. Everybody's trying to get there, and now here's 20 more problems coming in from the outside. So the idea that you see here on the screen of cleaning up content, I need to be able to do that as well against content that comes in from the outside. That's one of the most tedious jobs that a clinician has. I have a nice little tightly controlled problem list with 20 problems on it, 15 more coming in from the outside. I am supposed to take time out of my clinical day and decide which of those need to be incorporated on the current list and which ones don't. And it's exactly the same kind of tool I need, I think, that you're seeing on the screen here, but it needs to be able to act against those inbound problems, because they're going to be loaded with duplicates. They're going to be loaded with stuff that should have timed out. They're going to be loaded with related kinds of problems. And that I see going forward as one of the toughest things to do around this idea of problem list management, is how do we manage our problem list when we get to a world where everybody's sharing all the problems on on a patient from everywhere that patient got seen. So it's been an interesting discussion for us to get in front of customers and chat that up a bit.
Yeah, I agree. You know, I think that it really speaks to the notion that, look, from a physician or provider perspective, if there's an expectation for me about the problem list or about anything in general, then give me the right tools to be effective and make that easy to do. And whether it's problem list reconciliation or keeping an in-house problem list clean, the right tools can make expectations more efficient.
So when I've chatted up customers about the idea of maintaining your problem list management, cleaning up your problem list, whatever term you want to attach to that, at least half the customers, especially if there's when there's docs at the other end, their immediate question is, well, why do I have to do it? You know, look, your computer has identified that there's the following things on the chart that need to be cleaned up. Why can't you just do it? I don't want a pop-up. I don't want an alert. I don't want to have to do any clicks. I don't want to go into this problem list and manage it. Just have the computer clean it up for me. So the question kind of always sits on the table, whether we show our tool or whether it's some of the workflows that have been developed by other developers. You know, is it possible to completely automate the cleanup and not have me as a clinician have to touch anything? Jonathan, I think I'm going to start with you on. I'm going to start with you on this one, and then come back to Deepak.
So this is in our group of three. We have had many discussions about this. First of all, because it has been that a number of customers' requests, and I think that the three of us have gotten to the consensus that we don't have a consensus. The problem is twofold. First, is it possible to identify things that might be candidates to automatically demote from the problem list and put them wherever in past medical history or other places? It is possible, and I think that what Deepak presented a moment ago about these things that are flagged for cleanup are good examples. Is it wise? And that's where it becomes a real question. You know, you said it correctly, Jim. We are becoming more and more interoperable with other systems, with other docs, with other healthcare organizations. And it may seem to me that this is something that I should demote from the problem list and as I said, move it elsewhere, it might seem to another doc that that actually must stay there. If I look at this list and say, can we automatically clean it up? I really feel uncomfortable, even with the duplicate group where it has CHF and congestive heart failure as duplicate groups. If I were to say, well, the one with the note probably is the one I want to keep, it might be that the one with the note is a more recent version, and I really want to keep the original onset date for that on the problem list, as listed that the person has had congestive heart failure for a longer period of time. Probably a better example is that related group where there's a note on chronic sinusitis, which happened in 1999, but the more highly specific diagnosis, chronic left maxillary sinusitis, is probably what I would like to be represented on the problem list. What are your thoughts?
Yeah, I agree. The only thing I'd add is, it doesn't have to be all computer or physician as a binary choice, right? There are other roles, other people with clinical knowledge that can make an assessment, and that comes back to this notion of governance, of workflow, what your local, if you have MAs or nurses, for example, people that are rooming patients or touching the patient, connecting with the patient before the provider walks in, as reviewing the problem list, there are many opportunities, not just the software and not just the provider, but different opportunities that can be tailored for every scenario to keep problem lists cleaned up and reduce the burden on the provider at the same time. So I just think the notion of automating is not necessarily truly automating, but making it efficient for all the right people.
Yeah, we have had a number of customers who have said, look, we're going to write scripts on our side and get rid of some of the junk that we know is on all the problem lists. And, so for example, you get organizations where a whole lot of fairly trivial encounter for an annual health visit, or fairly trivial things, patient is dizzy, that doesn't really add anything. So there are these categories of problems that an organization says, look, we're going to clean these up automatically. Then the next sort of level up from that are things like real problems that landed on the chart that are duplicates or substantially redundant or should have lapsed. And those, I think, probably can be automated, although I would say from our perspective, as a vendor of some of these solutions, we sort of think some of those decisions should land with the organization, so maybe what the electronic health record ought to do is offer you as an organization the option of saying, look, we want to automate this, and the clinician never sees what got cleaned up off of there, or we're going to put it in front of you and have the clinician kind of sign off on it. I think that degree of automation is possible. But there's a second layer that I think can be automated very safely, and it's a direction that I would like to see sort of the problem list display go, and that is there ought to be a way to collapse the information on there so it's still contained. It's the same original problem list, dirty as it might be. It might be 20 or 30 problems that are cluttering up that list, but I think the computer can go into there and say, look, here's all and then fill in the blanks of the different kinds of problems that are on there, maybe by clinical category, cardiac and pulmonary and so on, and kind of collapse those so that each clinician gets to decide how they want to see that problem list. If I'm an ophthalmologist, I don't have to review every single ortho problem on there. So I want the problem list manipulated in some kind of automated fashion that doesn't necessarily clean it up in terms of its content, but it cleans it up from a display perspective. If there are 17 diabetic problems on there, let me have a line item that says diabetes, and then when I hit this summary view or this cleaned up view or whatever, it can distill the problem list down into the ones that are useful for me. As far as a purely automated cleanup, I think I'm very anxious about a purely automated mechanism to clean up the original list for exactly the reasons that we've mentioned. Sometimes there's metadata attached to something that you want to go away, but you want that metadata brought forward in some way. And sometimes the nuances that are in there are critical nuances, even though superficially they might seem to be relatively the same. The next area that I want to turn to is even trickier, so to speak, and not just cleaning up the display, but having the computer be able to go into an electronic health record and say, look, I can actually improve the problem list based on data that's hidden or exists elsewhere in the electronic health record. And I can go in and retrieve some of that and say, hey, look, here's what's on your problem list right now, but we can improve this problem list against the rest of the data that's in the electronic health record. And to the extent that we can automate that, I think it would be spectacular. And Jonathan, I think you've done some work around that.
So thank you. Ultimately, you've got a patient in front of you who has all of the problems, all of the information, so to speak. When you've got the electronic medical record, you've got a summary of that patient's health record, and the problem list is that summary, the summary of the health record. But we need to expand our understanding of what's actually in the electronic medical record beyond just what that problem list does. Sometimes that list is not as inclusive as it should be. Sometimes there's data that's in that patient's record that never bubbled up. No one ever recorded it in the problem list, or it was pushed to a different section altogether. What you're showing now is a patient, a de-identified patient. We did a study a number of years ago of a federally qualified health center, and we asked a relatively simple question, which is, I've got a problem list for a patient, and I've got the visit diagnoses for the past 2 years. Are there things on the visit diagnoses that probably should be moved over to the problem list, that are important enough to be moved over to the problem list? We used a screening device, which was simply to say, those things that have hierarchical condition categories, those HCCs that's put out by CMS, that those important diseases that we get a higher reimbursement for, and that's not why we were doing the study. We were doing it to identify some important illnesses. Could we use those to pick up on the visit on the problem list? And comparing the previous list, and this is the same patient, we found things that had not been listed, such as previously it said essential hypertension. It turns out that this person not only has hypertension, they've got congestive heart failure, they've got angina pectoris. Previously it said that it was uncomplicated diabetes type 2, and here we've actually found that the person has macular edema and retinopathy. Previously it said that there was some sort of alcohol dependence, and we find when we went through the HCCs for this patient's visit diagnoses, they actually were alcoholic, and there were additionally, this patient had schizoaffective disorder. The point of this is that within the record, and not just the problem list, there will be things that probably would be important to move over to the problem list to get you a better idea of who this patient is.
Thanks. So I have to say, any mention of HCCs is very anxiety provoking for me. I've gone on record with customers and others saying, look, we're trying to talk about the problem list today, and the first question I hear from you, and this isn't always from the CFO, it literally sometimes from the CMO or the CMIO or somebody else in the organization, is that presentation around improving the problem list was so great, but hey, how are we going to take cost out of our system, or how are we going to get a financial return if we improve our problem list? And just this morning in HIS talk, there was an anesthesiologist complaining about a particular electronic health record, but I'm not throwing them under the bus. This is all EHRs out there, I think, that the focus has been to make it a billing machine. I think the way he put it, with some text management on top of a billing machine, and it wasn't clinically emphasized. Okay, fine. So having said that, I don't think that our organizations have the luxury of ignoring finances either. Yes, we need to improve the problem list from a physician's perspective, a nurse's perspective, a caregiver's perspective, but you can't go anywhere to any conference these days and not say, how can we sort of optimize our reimbursement? And anyone that knows anything about the whole E&M world out in the ambulatory world knows that the central place you start for your E&M coding is, what is going on with this patient from a problem perspective, because you can't get to their evaluation and management until you start with that initial problem. So I just wanted to take a moment here and say we are sensitive to that here, and we get it that it's an issue across the nation, and until our crazy way to pay for healthcare improves, there does need to be a continued focus on how do I go to a problem list and finish my clinical care, and then have a display or an extraction or some way to bring forward to me what I actually need to document against to get paid. Because as the title on this slide says, ultimately, we don't really get paid for what we do. We get paid for what we document, because what we document against it what gets sent off to the billing company. So I just wanted to say we're cognizant of that when we do our work with the problem list, of how important that is to pay attention to. So leaving that aside for a moment and keeping an eye on the time here, I want to give us a chance to address the question on the slide here, which is whether or not there is a standard for the problem list, or perhaps even a standard list organization, or who should be in charge of it. Is it just going to continue to be different within every electronic health record across the entire country, depending on who's in charge at that organization and what what electronic record they have? Deepak, I think I'll let you chime in first on this question, recognizing that it's going to remain a little bit rhetorical.
Yeah, and thanks, Jim. I'll keep my comments here brief. The short answer is I don't think so. Intentionally. I think content and the management of that content can be streamlined and made more efficient and standardized, as we've been talking about. But I feel passionately that for adoption to occur, for providers to use problem lists more effectively as sort of their problem-oriented view of the chart, et cetera, that it has to be part of the EHR experience. It has to be the user interface, the metadata, all of that stuff, and how downstream functions utilize the problem list. All has to be integrated to each EHR. And as you all know, each EHR has its own unique approach to a variety of these peripheral functionality that either utilizes the problem list or feeds into the problem list. So I think content should be standardized in the management of that content, as we've been talking about, but the user experience should intentionally be more consistent with each EHR overall experience.
Jonathan, a standard for the problem list other than the Jonathan Gold standard?
That's always a question. I don't. I think the standard ultimately is how do we communicate from one organization to the other. What fits into the problem list really is in flux. I don't know that we can get to that standard yet.
Yeah, my thoughts on it are that we probably do need a standard down the road. We need an organization that says, look, here's the standard way for a standard problem list. The computer still needs to be flexible in terms of bringing different displays and different workflows that are specific to that particular electronic health record. But I would like to have us not us as a nation, or maybe the federal oversight committees, I would like to have them not go too far down the road right now for what the standard should be, because I think there's too much innovation that's constantly ongoing. Until we get an idea of what the computer can bring forward to us, I think it's a little early to start writing standards about exactly how that should be displayed. Having said that, I think there is a value in a clinician being able to go to almost any electronic health record and have a fairly predictable way in which they're going to get a clinical snapshot of that patient, because the EHR world evolves so rapidly. It's nice to go from one to the next and be able to, navigate around for that basic clinical snapshot. A comment or two on what lies ahead from either of you. Jonathan, I'll start with you here.
Sure. I think that the most important thing, if there's one thing that you take away from anything that I've said so far, is we need to change that mindset of the electronic medical record is pixelated paper. Okay? We need to change the mindset from pixelated paper, which does everything that you can do on paper, but no more, to something that's a dynamic, integrated guide for the clinician. The electronic medical record, because it is electronic and because it has data and because there are certain standards for that data, should allow us to do new and innovative things. And I'll just throw out a teaser. We can associate a problem with labs and meds. Why can't we do that from the problem list? We can do it with procedures. There are so many things we can do that are different from paper. Let's get out of that paper mind frame and move into the 21st century.
I couldn't say it better. All these notions that we're talking about go back to what both of you are saying, which is make it a dynamic, three-dimensional, interactive tool and a window to the chart.
Yeah, for me, fundamentally, what lies ahead, or what should lie ahead, is turning the problem list into a functional dashboard for me. If you want to take a simple metaphor from the real world, if I'm an airplane pilot and I have hundreds of data bits coming from all of the things that are going on with that airplane, if all I could see on my dashboard is a list of what all those data points are, I would be flying a very unsafe aircraft, right? Because number 67 might be your right engine is on fire. And we have to take that same paradigm into the problem list and say there are ways for the electronic health record and the computer to mine that information, that list of diagnoses, and present it to the clinician in such a way that whenever they go to the electronic health record, that clinical snapshot that Dr. Canner was talking about, that pivotal place for my care is all there right in front of me, and the problem list itself has aggregated the information from around that chart, so I get an actual dashboard of what's going on, a 3D view, and not just a two-dimensional list. So I think we'll stop there and give a few moments for questions here. We just have about 5 minutes or so left. Any comments before we get to that, Deepak or Jonathan?
I think we should go ahead with those questions.
Okay, well, let me take one of the questions that's near and dear to my own heart, which is that when the work that I do here at IMO is essentially trying to organize a problem, as simple as that. We give you a million terms. How do we decide what term goes into what particular display category? Where does it fit in on my dashboard? And what do we do with terms that go to more than one place? This is probably the commonest question I get. Hey, do I give diabetic retinopathy to the ophthalmologist for for her display, or do I give it to the endocrinologist for his display? What do we do around that? And my answer to that question is, if you just want a problem list where everything is put into only one display category to make it easy to view, it's okay if that's an arbitrary decision. Neither one of those is right, neither one of them is wrong. But I think what the computer can bring to the table is the ability to serve up to the endocrinologist what he's looking for, and also serve up to the ophthalmologist what she's looking for. So it doesn't have to be an either or, it doesn't have to be a binary place to go unless I'm looking at a really simplified problem list, where I don't want to have it displayed in both places. If I'm looking at that kind of a list, then I think it's okay to make an arbitrary decision, and it's always going to be arbitrary because of the complexity of medicine. The next question is around who should be the primary driver for development in the electronic health record. When we're talking to some of our vendors, they say, you know what, I want to hear it from our customers first. At IMO, we're kind of a third party. We bring a lot of ideas to the table. And then obviously the developers of the EHRs themselves also have the option. So Deepak, you work with a lot of customers. Where do you think the driver should come from for further development for the problem list?
Yeah, that's a great question. I think it can happen either from EHR vendors or from third-party providers. I think deployment and integration are key considerations. So I don't think the question. I would reword the question about what is the outcome, what is the user experience that your providers are trying to get out of. What problems are you trying to solve? EHR vendors can do a wonderful job of an integrated UI, right? Integrating with the rest of their EHR experience. But IMO, for example, or other providers, can use their expertise, in our case, around content management and organization and knowledge, content knowledge, if you will, to and deploy through smart on fire approaches or other ways to take a best in breed solution or a knowledge and experience and marry that with a balanced user experience with the EHR. So both options are available, and I think the market should go in both directions, candidly. That way the providers can choose, organizations can choose what works best for them.
There's a couple great questions here that I want to tackle. One of them is, why does a user have to see all this extra stuff on a problem list? Things like an ICD-10 code or whatever. What can we do about the visual UX, the GUI? And then the second question that I want to tackle is where do things like a past medical history go? Because both of those for me is kind of a display guy are the same question. You know, what can the electronic health record do to make the problem list serve up what it needs to whoever happens to be looking at it? If I'm looking at it and I need a lot of detail, I want to be able to hit something that says, give me all the detail, including the codes behind the problem, for example. And I also want a button, sort of a filter that says, give me the sparse view, give me the overall view. So in a view that's not sparse, maybe I go to a different tab to look up the past medical history and it's parked there. But I, as a clinician, think I also want a view that parks the past medical history of X under the appropriate category. If somebody's got a past history of a cholecystectomy and I'm evaluating that patient for some GI complaints, I want to know that, and I don't want to have to go to a different tab. And I think the whole idea here is to use a computer wherever possible to create different displays for the different situations, whether I'm a specialist or a primary care doc, or whether I'm looking for a lot of detail or not. There's a question in here, Jonathan, about the onset date and how we handle that. And I think just looking at the time, maybe I'll close with that. But you've done so much work around this idea of sort of the temporality of problems. Can you just talk for just a moment about the overall idea of temporality and association with problems?
Sure, and I think if you haven't been able to read, if you can look through the questions, this is also a really important question. Onset date may very well capture the first time anyone ever addressed an issue. So in 2003, when the patient came in and said, "Doc, I've had diabetes for the past 20 years," it's captured as 2003 is the onset date for that diabetes. It's not necessarily. I mean, there may be a note that says beginning in 1983, may or may not be. It's there is a bit of a problem, and it's also a bit of a governance, and it's also a bit of a vendor problem. What is captured as the onset date? I think that it is important for us to be able to mark down when things actually started, and this is what we were discussing before when I said here are three different examples of, or here's the example of sinusitis, where the very vague diagnosis happened in 1999, and yet we've got a really clear understanding that's happened in 2017. Wouldn't it make sense to capture the correct up-to-date diagnosis and yet acknowledge that this has been an ongoing problem since 1999? So I don't have a solution. It really does boil down to what is allowed by the vendor and what does the doc capture as important. And I'll wrap with that, Jim.
Yeah, I see that we're at time here, and so if some of you have to drop off, go ahead and do it. But I think we'll take a few extra minutes on our side and kind of work through a couple more of these questions that are online here. Deepak, do you want to tackle the question about how does IMO's problem list treat harmful BRCA variants found in a phenotypically breast healthy patient? So this problem is a little bit more about our terminology maybe than the problem list itself.
Sure. You know, I think my take on the question, without being able to seek clarification, is just sort of how do you handle descriptions of conditions that are not necessarily, like, as the question said, phenotypically presented itself yet. From a content management perspective, so I think about the problem list and where we put terms and conditions. We want to make, this is a good example where we want the categories, we want where conditions show up to be in a clinically reasonable place. It doesn't have to be perfect. And in fact, the reality is, in these BRCA gene mutations and all the permutations of that all the way through phenotypic expression are great examples of that, where we could argue about whether does it go in a genetic category, in a different categories, just depending on use cases. The reality is, to make it a pragmatic tool, let's put it in one and only one place in a clinically reasonable category. So at IMO, I believe we have a category for hematology and oncology, and we will put BRCA as well as breast cancer, as well as breast cancer metastasized to pelvis, right? Or other oncologic conditions in the same category. There's no one way to parse out the book of medicine, but as long as we're clinically reasonable and accurate, then it's a reasonable place that providers can find conditions, whether it's a gene mutation or an expression.
I agree with that. For what it's worth, when I've done the kind of grouping that we've done for a problem list display, if a patient's got identified on the problem list that let's say they're positive for the BRCA variant that's significant for breast cancer, I think that ought to go in breast cancer. It ought not to go under a taxonomic grouping such as, chromosomal abnormalities, for example. So the rule of thumb for me, when I try and do some of this grouping, is the problem list needs to present to me as a clinician what's useful as a clinician, not necessarily where something goes, you know, taxonomically. I want to come back to another, go ahead.
Oh, I'm sorry. And just to add to that, another benefit of putting it with a broader hematology condition is that it has implications for beyond just breast cancer, right? Whether it's ovarian or prostate or what have you. So having it in a clinically meaningful place matters more than ontologic precision.
Yeah, totally agree. I want to come back to another topic that we addressed kind of at the top, and that is this idea of a tool to help me manage inbound problems. Problems come in from the outside world. What kind of tool are we talking about that might help a clinician? The first one for me is a tool that displays what's coming in against what's already on the chart in the same clinical category. So here's some coronary stuff coming in. I want a tool that gathers up the coronary stuff that's already on the existing chart and say, look, here are some proposed additions. Are you interested in adding these because they came in from the outside? Are they adding value, or are they already on there? And then I think the second thing that tool needs to do is to be able to display over in a sidebar what my proposed additions are. So I can kind of see the final list when I'm bringing in this outside tool. I can run the rules engine against it to say, here's what's already on the chart that's germane to this. These are duplicates maybe. These are just kind of similar. These are brand new. And then cull out of that as rapidly as possible what that final list is going to be when I've finished incorporating that outside stuff. In order to do that, the tool has to be able to sort of see or take a look at the candidate problems that are coming in from the outside. Jory, do you want us to take a few more minutes and tackle some of these other questions, or do you want us to close it out here and try and get back to the answers, you know, via written communication?
So it looks like our audience is winding down. Why don't we do this post-webinar, and we'll send out communication to everyone who asked a question.
Okay, well, thank you so much for participating, and thank you, Jonathan and Deepak, not just for being here on the webinar, but for being some of the fellow brains in our brain trust here at IMO thinking about this. It's been a real pleasure talking to everybody today. We hope you enjoyed it, and feel free to contact us for any further follow-up questions or information or any other of our input around the problem list.
Thank you all.
Thank you.